Okay, we are streaming. Just let me pop over to Facebook to confirm. And there we are. All right. Oh, a lot of people joining quickly. Great. Let's not keep them waiting any longer. Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation and Neuroendocrine Cancer Foundation program. Pardon the delay. We had a little bit of technical difficulties, which happens when you're using technology in this manner. But hey, we're here. We're going to keep the show must go on, right? So here it is. If you don't know me, my name is Rain Bennett. I'm your host this episode and every episode, and I've been working with NCF and now or CCF and now NCF for well over 10 years. I started creating videos for the Carcinoid Cancer Foundation in 2012, I believe. And over that decade plus, we have created, well, I've lost count how many videos, but all different kinds of videos, patient-centric documentaries, Q&A sessions like the one you'll watch today, dense treatment-based videos, but all with one mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That's what we're here to do. Now, if you are new to this community or new to this show, I want to say welcome. And the value that you will get from this show specifically is twofold as I see it. One, the information and hopefully answers to some of your questions from our special guest today, as well as the shared experiences and shared stories from within the community, the folks also here on the show, people that have been a part of the show for 5 years. So you can see some of the people in the comment section saying hello and where they're signing on from. I encourage you to do the same thing. I encourage you to reach out and embrace the community because they will embrace you back. This is one of the things that is most striking and most profound to me about the NET community is how supportive it is, whether it's caregivers, support group leaders, patients, and providers and specialists and experts and doctors. The strength of the community is very, very special to watch and to witness. So if you are new to this journey, again, we will reiterate, lean into that. It will help you along the journey. So before we get started, we want to thank our presenting sponsors for this show. Couldn't do the show without them. So their support and your attendance helps us keep the show going on every month. And as I said earlier, we've been doing this for about 5 years now, which is insane, to be quite honest, but we are a product of the pandemic and we are still going strong. Now, this doesn't happen so often after those 5 years, but we have a first-time guest today, a rookie for Luncheon with the Experts, Dr. Claire Mulvey. Dr. Mulvey, how are you?
I'm doing well. Thank you so much for having me on the show, and apologies again for the slight delay in getting
No
started.
worries. It happens. Hey, we're here. That's what we're excited about. Sometimes, technical difficulties happen and we're not even able to, we have to reschedule and the people still attend. So we're very, very grateful for that. Now, I'm grateful for you being here. For those that may not be familiar with you and your role in this NET community, I just kind of alluded to, tell us a little bit about what you do, where you work, and how you serve this community.
Sure. I am a thoracic medical oncologist, so my training is specifically in lung cancers. And I treat a wide variety of lung cancers, including non-small cell lung cancer, but my particular focus has been from the beginning, neuroendocrine cancers of the lung. So that includes carcinoid tumors, well-differentiated neuroendocrine tumors, and then also the high-grade neuroendocrine carcinomas of the lung, small cell lung cancer, and large cell neuroendocrine carcinoma. I've had this interest ever since I was a fellow. I trained at UCSF, which is where I work now. I trained with Dr. Emily Bergsland initially in the GI group. So I have some GI, experience and focus. But since I've been an attending physician, I've really been in the thoracic group. So I've sort of carved out this unique niche of lung neuroendocrine tumor focus.
Yeah, absolutely. And that's exciting today because we always get questions about lung nets and it might be, someone who specializes in GI and they'll still try to field those questions. But we always get lung net questions, which is why I'm excited to have you here. Now, I'm curious, how did you know, or what was the thing that drove you to that at such an early stage in your career? Generally, I don't tend to see that. It happens kind of in this meandering path,
Right.
but you said you kind of specialized in that really early.
I had an interest in endocrinology initially when I was in training, and I was fortunate to be connected with Dr. Berkson really pretty early on. And I was just so struck by the power of the neuroendocrine tumor community, both from a patient perspective, and then also from a research perspective. You know, the doctors who take care of patients and the researchers who study this condition. It's not a huge community. We know each other. It's a very supportive community. And I just was so drawn to that from the beginning. So I thought about doing other things at various points, but I always came back to neuroendocrine tumor focus.
Yeah. So folks at home, that kind of validates my stance about the community earlier. I'm not just making this up. It's very true. I think it's a good point that you indirectly bring up about the size of the community. I mean, because I often question and I haven't spent as much time in other cancer communities. So I don't want to say it doesn't exist there, but other people have told me that
it's very unique.
It's not just something. Yeah, right. Other people have said that. So I don't like to make that leap or make that assumption, but I've heard it, parried back to me as you just did that it is accurate, and maybe it's the rarity of it. Maybe I'm not sure.
And it's not,
but
it's
it is
also
something.
the fact that I learn from my patients. You know, I think patients are really, because of the support community, folks are empowered to learn about their disease. People do get multiple opinions at times, and so I learn from my patients sometimes. I think I'm always impressed by how much, depends where they are in their journey, right? As people are first diagnosed, won't know very much about neuroendocrine tumors, but compared to other cancers, I've been just so impressed with the neuroendocrine tumor patient community.
Absolutely. I think it's such a valid point you make about this kind of collaboration, this kind of two-way street. And I've heard those sentiments echoed before by other doctors. And I've heard that the show helps facilitate that a little bit of this, this two-way street. And that makes me feel really good about the impact that we're having, that it's not just on patients, it's also helping folks like you maybe view things from a different perspective or help them do their work better. So it just completely continues to strengthen that community, which I love to see. Folks, before we get started, a quick little announcement from me and some of the projects we're working on. I think I've mentioned these before in the past, but I just got back from Mount Sinai. We're working on several documentaries this year. It's 2 shorter ones, the patient stories that you all are probably familiar with, and one large project, which is intended to really showcase the strength of the community, the NET community, and to be this kind of big flagship piece, which I'm very excited about. So one of the videos that we were shooting this week, I got to film PRRT at Mount Sinai, which all the years I've been working alongside NETs, I've never actually seen. And I will say it's not that visually exciting, it was an IV. But they bring it out in this little box that they have, and they present it, and so that part was kind of cool and kind of exciting. But shout out to Ilka Peters, who were telling her story, her and her son Shane, who is very omnipresent here on the show, typically asking questions. I had a great time, but that was kind of cool to see. I know we get a lot of questions about PRRT, so you all will be seeing that documentary in maybe a month or two. But that was a cool thing.
And that's sort of a segue into one of the things that's different sometimes for lung neuroendocrine tumors. I mean, unlike other primary sites, neuroendocrine tumors of the lung are not always very avid on a dotatate PET scan. And so PRRT is not always a good option for treatment of patients with lung NETs. And that's sort of one example of, there are a few things that are different about lung NETs than other primary sites.
We'll get it. Let's get into all of those things. Now I have a lot of people from YouTube today, which is exciting to see. That community is growing. But I have Jean from New Jersey, which I was just there in New York and New Jersey. Jean, so hello, who's first time here, welcome, and newly diagnosed lung NET. So this is the community, this NET community is very well educated, but I always like to make sure that we play to the folks like Jean who are very recently diagnosed. They may be confused, they may be scared, they may have never heard of this cancer. And since we're kind of talking about the differences of lung NETs specifically, could we, this is kind of a big question, but could we kind of lay some groundwork for someone like Jean who's newly diagnosed about really what a lung neuroendocrine tumor is? You've already touched on some of that, but let's just kind of set some foundation and then we'll build upon that if that's okay.
Sure. So when I think about someone who's newly diagnosed, there are a couple of concepts for any neuroendocrine tumor that we try to explain to patients in a new visit. And the first is to just really understand your diagnosis. I think that's something that is hard to wrap your mind around because there's so many complicated terms that we use when we describe a neuroendocrine cancer. And some of the terms are really important as you think about what treatment you might have available, what you might expect in terms of the tempo of how the tumor might behave. So we talk about things like, what's the differentiation status? Is it well differentiated or poorly differentiated? We talk about the grade. Is it grade 1, grade 2, or grade 3? And then we talk about the primary site or where it started. So for lung neuroendocrine tumors, those are neuroendocrine tumors that start in the lungs. Sometimes it's really obvious that it's a lung neuroendocrine tumor because the only tumor is in the lungs, and then kind of by default, we know it's a lung neuroendocrine tumor. Other times, if people are presenting with stage 4 disease, it may be hard to tell. If it starts in the lungs, usually there's an obvious, somewhat obvious tumor, a larger tumor in the lungs. The largest tumor might be in the lungs, but not always. We can also get a clue from histology. So what they see when they look under the microscope, they do different stains to try to figure out for a neuroendocrine tumor where it started. And the neuroendocrine tumors that are carcinoid tumors, or the slower growing, well differentiated versions of neuroendocrine tumors, they are sometimes stain positive for something called TTF1. So if your tumor stains for TTF1, it's a lung neuroendocrine tumor. But the converse is not always true. So there are lung neuroendocrine tumors that do not stain positive for TTF1. So if that stain is negative, it doesn't tell you for sure. But if it's positive, you can feel pretty confident it's a lung neuroendocrine tumor. So those are the sorts of things that we pay a lot of attention to at the beginning, is getting a sense of, is this a slow growing neuroendocrine tumor or one that might be a bit faster growing? Because there is such a spectrum of how these cancers can behave. And that's true for every primary site, but I think especially for the lung.
Got it. Thank you. Folks, go ahead and start sending in your questions now. I see some already lined up in the queue, so we'll get to those in just a moment. But a little bit of best practices for you, especially for you newer folks. It's very hard to answer super case-specific, super dense questions in this format. So try to formulate your questions in small, generic chunks. There's no limit to how many questions you can ask. So you can always ask follow-up questions. Dr. Mulvey might ask you for more clarification, for example. But as we get one answer, it's kind of like a trail of breadcrumbs. It might lead to the next question. Totally fine. But it's just easier to address them and field them in short, generic chunks like that. Okay. Rachel or Rochelle, please remind me how to pronounce your name. I know you told me before, so apologies, but welcome back. How do you know if you have lung nets? I have confirmed gastric nets and a moderately severe FEV1 score. So I guess she's wondering, could that be related?
Yeah, so I think for that question, my first thing I would wonder are there any tumors in the lungs? Are there any nodules in the lungs? It's hard to have a lung neuroendocrine tumor without having any nodules in the lungs. So oftentimes on scans, we can tell just based on the distribution of where different tumors are. So there's kind of a classic way that lung nets can present. There's usually nodules in the lungs. And then as the tumors start to spread, they often spread into the lymph nodes nearby in the lungs and in the middle of the chest. And then from there, they could spread anywhere. But there is sort of a classic way that what we expect to see on scans. And then the other way is, as I mentioned before, is whenever you have a biopsy, you can ask that normally they'll do some staining to try to figure out where it came from. And TTF1 is kind of the lung specific stain. So if a tumor does stain positive for TTF1, if it's a carcinoid tumor, that's fairly specific for a lung neuroendocrine tumor. Now, that does not necessarily hold for the more aggressive neuroendocrine cancers like neuroendocrine carcinomas. The staining isn't as reliable in that setting. But for a carcinoid tumor, if it stains positive for TTF1, then you can feel confident it's a lung net. But in terms of a reduced FEV1, other things can do that. That is a test that's generated from a pulmonary function test. And it's a marker of some lung obstruction, but it doesn't necessarily have to be from a lung neuroendocrine tumor. It could be from asthma or COPD or other conditions. So I'd wonder if you had any lung nodules.
Got it. Thanks for your question, and let us know if you have any more information or a follow-up question. Laura asked, where do you practice? Laura, if you missed the beginning, is that UCSF, University of California at San Francisco. By the way, I wanted to say extra shout out to Dr. Bergslin, who is incredible, and I've had the chance to work with her before. She hasn't been on the show in a while.
Yeah, we have
what a great mentor.
Here, so
yeah, for sure. Okay, so Brenda asks, what new treatments are being investigated for stage 4, grade 1 non-functional lung primary with Mets to the liver, if any?
Yeah, I mean, we are definitely behind, unfortunately, in that a lot of clinical trials exclude lung nets. They'll allow GI and pancreas nets, patients with those diagnoses to participate, but lung nets will be excluded. So if you look at the trials that are currently open and out there nationally, some of the studies are to try to prove that some of the treatments for GI and pancreas nets that are used also work for lung nets. So an example of that is there's a trial open right now nationally through the Alliance cooperative group that's looking at PRT and everolimus. So patients are randomized to either PRT or everolimus. And the study is trying to answer a few different questions. Does PRT work for lung neuroendocrine tumors for patients that have, dotatate avid lung neuroendocrine tumors? And then we're also trying to understand the sequencing or the ordering of treatment and whether it's better to get PRT first or if it doesn't matter if you could get PRT later after everolimus. So that's an example of a trial. It's not the most exciting study in that these are treatments that are used routinely for other neuroendocrine tumors, but we're trying to prove that they work for lung neuroendocrine tumors. I think a real unmet need for these patients is for patients that don't have very dotatate avid tumors. Is there some other marker that we could use to develop a different radionuclide therapy? I think there's some research that's being done to try to figure out alternative radionuclide treatments other than PRRT that might be effective for dotatate negative neuroendocrine tumors, and that's specifically relevant for lung neuroendocrine tumors. And then also there's some research looking at different growth pathways within the cells and trying to target new growth pathways to try to prevent tumor growth. And then across all different grades of neuroendocrine tumors, there's been some interest in what are called DLL3 targeting treatments. So DLL3 is a protein that in most normal cells is inside of the cells. But in many neuroendocrine tumors, especially the high-grade ones, but also to some extent some of the lower-grade neuroendocrine tumors, it's on the surface of cells. And so that has there's some research that's trying to exploit that through different potential ways, using the immune system, using antibody drug conjugates, and some of those treatments may end up being relevant for grade 1, stage 4 lung neuroendocrine tumors.
Got it. Thank you. From Larry, given that LungNet does not respond to dotatate as a screening method, I think you mentioned that earlier, how do you initially identify them?
Yeah, that's really a challenge. So some of them do. I mean, it's not that every LungNet is not bright on a dotatate. It's just that if you had a small bowel neuroendocrine tumor, if you had a grade 1 small bowel neuroendocrine tumor, by definition, it would light up on a dotatate. And then that becomes a really easy way to track people's disease. And then, of course, it also opens up other treatment options. Lung neuroendocrine tumors, it's just more variable. Sometimes they do light up on the dotatate. Sometimes they light up, but very weakly. So it's still a way you can find these tumors, but they're not bright enough to qualify for some of the treatments that are linked to the dotatate scan. And then other times they don't light up at all. We do have our FDG PET scan. So that is a sugar PET scan. So instead of the dotatate tracer, it just uses sugar with a little bit of radiation, and we look where sugar goes. Some tumors use a lot of sugar and they light up on an FDG PET scan. Those tend to be the ones that are growing a little bit more quickly. So sometimes we'll try to get an FDG PET scan and see if that's a way that we can visualize or try to find or track someone's neuroendocrine tumor. But sometimes we have to rely just on cross-sectional imaging, CT scans, MRIs, and that's the only way we have to track someone's neuroendocrine tumor over time.
Got it. Thank you. Huimin says, I have thymic nets and surgery in 2020, now metastasized to supraclavicular lymph nodes. Any chances for surgery?
Yeah, that's a great question. And I will just say that thymic nets are even more sort of an orphan disease than lung neuroendocrine tumors. They're even more rare and even more excluded from our clinical trials and general research. So definitely an area where there's room for more research. I typically think about surgery now, technically a supraclavicular node is a metastatic site. Whenever we think about surgery for stage 4 neuroendocrine tumors, it really depends on how many sites of disease are there, how quickly are they changing. And the slower growing a tumor is, and if you can remove the vast majority of tumor through any surgery, the more inclined we would be to do surgery, if that makes sense. So if a tumor's growing quickly, if there are lots of different tumors that are growing, then surgery is not the right answer. Then we prefer medical treatment to try to get some control. But if there's 1 or 2 spots and they're growing very slowly, then yes, sometimes we will consider surgery. Now, that location can be a little bit trickier, just in terms of like wound healing. So it would depend a little bit on how easy of a surgery it would be. If surgery isn't an option, the other thing we end up doing a fair amount of is radiation, external radiation. That can be another way to spot treat a lymph node or a tumor, 1 or 2 tumors, as an alternative to surgery. So potentially, but it might depend on the surgical specifics.
Got it. Thank you. Celeste says, is it ever possible to have a benign lung net?
In general, we think about these tumors as having malignant potential. Now, there is this condition called DIPNEC, or diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. That is this precancerous condition that's not very well understood. And it's basically just a tendency in the lungs to have neuroendocrine cells growing more than they should. And there's a spectrum where some people have a lot of microscopic neuroendocrine tumor cell growth. But that's it. It's just all sort of at a microscopic level. But it can predispose people to getting carcinoid tumorlets, which are collections of neuroendocrine tumors in a nodule that's less than 0.5 centimeter, or even tumors, which are bigger than 0.5 centimeter in size. So not everyone with DIPNEC has carcinoid tumorlets or tumors, but some people do. And there's been some controversy in the field about whether those neuroendocrine tumorlets and tumors are really malignant. Do they have the ability to metastasize and spread? And initially there was some controversy, but I think the most up-to-date case series suggests that even in that condition, there is the potential for them to become malignant. So the word carcinoid means cancer-like. For a long time, when these were first diagnosed, we didn't appreciate that they actually were cancers. And there are some lung neuroendocrine tumors that are really, really slow growing, but they are still tumors. I still think of them as cancers. And I think in general, they all have the potential to spread, but some of them might do so over a very, very, very long time. And to answer one of the other questions I saw in the chat, which is that, is it ever acceptable to watch and wait? It can be, all right? I mean, we always take into account how fast is something growing and we consider the person that the tumor is in, and whether it's likely to cause problems over their lifespan or not. And the urgency with which we need to act can be very variable depending on how fast or slow growing a tumor is. So yes, malignant potential, but a huge range in terms of how fast or slow they can grow. And there are some that will grow and change, but they do so over such a long time frame that we think they're very different than a lot of other cancers.
Mm-hmm. Folks, if you just joined us or joined us a little bit late, this is Luncheon with the Experts. We are here with Dr. Claire Mulvey from UCSF, talking about all things lung nets. I'm glad you brought up dip neck because it often gets brought up anyway, and it is somewhat misunderstood, so I'm sure we might get more questions about that today. By the way, was that Jean's question that you mentioned about can it be watched?
Exactly. I saw that.
Yeah, cool. Gotcha. Yep. Moving on, MJ says, any known impact of hormone replacement therapy by bioidentical for lung net cancer? Full mid-lobe resection in November 24. Should I stop the bioidentical hormones?
That is a great question. And I think the honest answer is there's not, enough research yet into this area for me to answer it definitively by any means. It's interesting. Unlike other primary sites, there is a gender imbalance in who gets diagnosed with lung neuroendocrine tumors. So lung neuroendocrine tumors happen more frequently in women than in men. In different series, it's anywhere from 60 to 70% of these diagnoses are in women. So there's a difference. And why that is, I don't think we have any idea. Whether hormones are playing a role in that, I don't think we have any idea. But it certainly, raises some questions about whether, there might be some hormonally driven element to this. But that said, there have been big studies looking at hormone replacement therapy. This is a question that comes up a lot for me in clinic for patients. There have been big studies looking at, at a population level, what the risks are for cancer. And I think the most recent thinking is that some of the cancer risks were sort of overblown and the benefits were minimized. So I think it depends on how much benefit you're getting from hormone replacement therapy. Some people, it makes a very dramatic difference in their quality of life, clear improvement in their quality of life. I'd want you on the lowest dose that helped manage your symptoms. Again, some of these things like estrogen is a growth factor. Again, so there are some theoretical concerns if you have cancer in place and then you're on these medicines. But I wouldn't necessarily as a blanket statement say you absolutely have to stop it, but it might change how I monitor you. So if I knew you were on one of those treatments, I might, especially at the beginning, look a little bit more often just to make sure that your tumor wasn't behaving a little bit more aggressively than I might have expected. And then if it was, then that might prompt the conversation. It might change that risk benefit assessment for, that particular person.
Gotcha. Thanks, MJ. Let me know if you have any other questions. And Rochelle, thank you for correcting my pronunciation of your name. Mary says, hi, I had an RRL in 2012. The tumors were all typical tumors. In 2018, I had a recurrence and I had an MRL. This time, the tumor was atypical. So the question is, how common is it to have neuroendocrine typical tumors removed and then have an atypical tumor removed a few years later?
It definitely can be something that we see. I'm not quite sure in this instance. I'm trying to figure out what the RLL and MRL. I mean, you can have, it might be that this is referring to different resections in the right lung.
Yes, that's okay. My assumption.
So it's not super common, but it is also something that we see. It sounds like this person has so the first question whenever people have multiple tumors removed in their lungs is, are they separate neuroendocrine tumors or did one spread to the other? All right. So that's always sort of the first question. And sometimes it's hard to figure out. We don't always know. We can't always tell. If in the background, normal lung, whenever you have a lung resection, if in the background we see dip neck, then I am more likely to assume they're all separate primary tumors because we know this is a neuroendocrine tumor predisposing condition. And people often have many primary neuroendocrine tumors. But if you don't have DIPNEC in the background, then sometimes it's a little hard to figure out, is this someone who just is prone to neuroendocrine tumors for some other reason? Or is there a chance that one spread to the other? But we know heterogeneity is common. So within neuroendocrine tumors, whenever we get a biopsy, we get a tiny little sample, and if you look at a whole tumor that's resected, there can be heterogeneity. There can be sections that are more atypical carcinoid and sections that look more like typical carcinoid. So it's a little hard for me to tell if this, again, if these were separate primaries or not, but it's not necessarily unusual to have slight differences in histology over time.
Got it. Thanks, Mary. Let me know if you have any other questions. From Anna, hi from Scotland. I had a lung surgery, 1 net tumor, stage 1, but metastases into 4 nearby lymph nodes and diagnosed with DIPNEC. Anna says in Scotland, the pathway is just to monitor, no medication or oncologist. So this is more just kind of a general question. What are your thoughts? Are there things that other things Anna should be considering or doing or pursuing?
I think the key is surveillance. It sounds like, and so, I mean, one question is, at the time of the surgery, did they remove all of those lymph nodes that had metastases? I'm assuming they did, and that's how they figured out, that the diagnosis was made at the time of her surgical pathology evaluation. But we would typically recommend surveillance. So we do surveillance both for anyone with DIPNEC, because as you follow people over time, the nodules can progress over time. And then anyone after a surgical resection, we would also recommend surveillance to make sure it doesn't come back. And the fact that it was in some of the regional lymph nodes at the time of the resection does increase the risk that it might come back. And this is a difference between neuroendocrine tumors and many other types of cancers. The difference is how long we have to do surveillance for. So after a surgery, we typically do surveillance for at least 10 years to make sure a neuroendocrine tumor does not recur. And for DIPNEC, we're usually getting scans every 12 to 24 months to make sure none of the DIPNEC nodules progress or start to metastasize or spread. So kind of for 2 reasons, the background DIPNEC and the fact that she had a neuroendocrine tumor removed, we would typically, at a minimum, get CT scans at least every 12 months for 10 years here in the United States. That doesn't necessarily, I suppose, have to be done by an oncologist, but I would say we would typically monitor here.
Okay. Thank you, Anna, and appreciate you joining us. I think this is the first time I've seen your name, so welcome. From Leslie, my child just had an atypical carcinoid net in her lung removed surgically with a lower lobe where it was located in December. She was only barely 11 years old. Is there any insight to how something so rare can occur in someone so young? I think this is a good question, because oftentimes people think nets are reserved for people that are middle-aged or older. Right. And that's just not true. But
it's not true. And I think, I'm not a pediatric oncologist, but I think if you think about lung cancers in children, neuroendocrine tumors are the most common lung cancer in children, with the idea being that some of the other common cancers that may be linked with things like smoking are really not at all common in kids. Right. And I think in some ways, it sounds like your daughter might have been, or your child might have been lucky to have been picked up and diagnosed. We have no idea why these happen most of the time. We do usually recommend genetic counseling. So hopefully that was discussed somewhere along the way, because if you do testing, about 10% of the time, there is some familial gene, that family members might have that predisposes you to get a neuroendocrine tumor. And certainly anyone diagnosed at a young age, we would want to look for that to see if there was something genetic that might have predisposed. But we don't always find it. And I have quite a number of patients in their 20s and even as young as 18 that we follow. So it is something we see in younger folks occasionally.
The genetic question, which actually Sean has a question right after that about, do you also pay attention to how genetics play into the manifestation of cancer? We get those questions all the time. I wonder, is it more prevalent in lung nets, perhaps?
I think it's a little bit more prevalent in lung nets. It's sort of like pancreatic nets, where it's a little bit more prevalent, we think, than for small bowel. And prevalent enough, if you look at the NCCN guidelines, which are the National Comprehensive Cancer Network guidelines that we all use as we take care of different cancers, they recommend at least considering genetic testing in everyone. And that's specific for bronchial nets. It's not necessarily true for every other primary site, but it's still only about 10% of the time. So if you do genetic testing, more times than not, there's actually not a predisposing condition, a genetic condition. But it's the kind of thing where we never want to miss it, because it can affect both individual patient screening every once in a while, and then certainly for family, there's more and more screening we can do. We knew there was some predisposition. Yeah. It's one thing to get the information and not be able to do anything with it. I mean, that I think really sometimes it makes a lot of sense. People don't want information you can't act on, but there is a lot that we can now do in terms of screening, both for an individual who might carry the mutation and then for family. I do want to just jump on one question, because this is another one I think is a really good one that's different for neuroendocrine tumors of the lung. Yara Salman asked if next generation sequencing, which is DNA and RNA sequencing of a tumor, if that is of any importance for a patient with advanced neuroendocrine tumor. And this is something that comes up a lot in clinic. For lung neuroendocrine tumors, absolutely. I think it is key for anyone with metastatic disease. And the reason why is, with any neuroendocrine tumor, we often see overlapping mutations with whatever are the more common tumors of that organ. And for the more common lung cancers, molecular testing has become standard. We have 10 different genetic DNA mutations where you get down a totally different treatment pathway based on which of the 10 mutations you have. And sometimes with lung neuroendocrine tumors, if we do the testing, we find one of those same mutations. And some of these mutations have really highly effective targeted treatments available. So I have a patient who had, when she was diagnosed, she had very advanced disease, brain metastases, liver metastases, all throughout her back and spine. And she ended up having what's called an ALK rearrangement, which is one of these molecular subgroups where there's you can take a pill, an ALK inhibitor pill. She's on a drug called lorlatinib, and she's had a miraculous response to it. And if we had never done the molecular testing, we wouldn't have known that would have been an option for her, because it's not something that is commonly used in neuroendocrine tumors. So we don't always find a mutation. I would say more often than not, we don't find something we can target. But it's one of those things I would never want to miss. I'd never want to miss an actionable mutation that there's a pill for that might work better than some of other treatments.
Gotcha. Thanks, Yara. Jean says, is it typical to be sent after a bronch/biopsy PET straight to the thoracic surgeon for lobectomy, or should patients be seen by lung net specialists prior to any surgery that they may have?
Ooh, that is also a great question. I would say that yes, it is very typical. All right. I think there's a perception in the community that these are slow growing, they just need surgery, then you're cured. And why would you see a medical oncologist, sort of in between if it looks like it's resectable? And, often if it's localized, if it hasn't spread anywhere, then surgery usually is the right answer. So it's not that the referral to the surgeon is wrong. I think the downside with doing that sometimes is we miss the opportunity to get a dotatate scan. And sometimes the surgeons, or if you're not seeing a medical oncologist, they might not do the full staging workup before surgery to make sure it hasn't spread anywhere else. So obviously you've had chest imaging, right, to pick up a lung net. But sometimes people don't have abdominal imaging or don't have good quality abdominal imaging, which we think of as being with contrast. So ideally, you get a CT or an MRI. The MRI, we like to get EAVIST contrast. It makes a really good picture of the liver. But you need some good abdominal imaging to make sure it hasn't spread into the abdomen. And then it's nice if we can get a dotatate scan before surgery, because once the tumor's out, we don't know if the tumor lit up on a dotatate scan. So we don't know moving forward if dotatate is useful as a way to track and look for a recurrence. So if you get it done before surgery, then we have the information because we know where to look. But it's not always absolutely critical. Again, for a small grade 1 typical carcinoid that has, very little chance of having metastasize or spread, it's not necessarily wrong for them to go right to a surgeon to get it resected. The other thing with seeing a thoracic surgeon, though, gets back to what we were talking about earlier, which is you really need long-term surveillance for at least 10 years after any resection. And the surgeons are often really good for the first 6 months, 12 months at following patients and, making sure they recover from surgery. But it's not always playing to their strengths and scope of practice to follow someone for 10 years. It depends on the surgeon. And so sometimes I see people get lost. They get a couple years of follow-up and then it stops. And then they present many years later with a recurrence and they should have been monitored more in the interim.
Brenda says, how do you think we get more research attention on lung nets?
That's such a great question, and it's such an important issue. I think as patients and patient advocates, raising attention to this is one way of trying to do it. And even simple things like some of the carcinoid tumor foundations have funding specifically for grants focused on neuroendocrine tumors of the lung. If there's funding available, then that can also sometimes help researchers who are trying to get started pay attention to this disease area. But it's definitely an unmet need.
We kind of touched on this earlier, but Jim says, has PRTA been accepted medically and insurance-wise for possible treatment of primary lung nets origin?
Yes, good question. I think there's some debate about whether PRT, is this PRT alpha? I can't PRT alpha. Is that what A means?
I believe so.
Yeah. So okay.
I believe so, yes.
I am not aware. So that is, looking at a slightly different radio tracer for PRT, and there are some advantages with alpha emitting particles having more energy than the gamma radiation, but also not traveling as far, so maybe not causing as much side effects and collateral damage. Most of the trials that I'm aware of are really focused right now on pancreas and GI nets. And currently it's, there's some exciting data that's being published. I think that there's a lot of enthusiasm for these approaches, but they're still, for now, in the United States, largely being done in clinical trials. And many of those clinical trials don't allow, yet, at least, lung neuroendocrine tumors. So this is another area where we're a little bit behind, unfortunately.
Got it. Thank you. Well, Gayla says, are there any blood tests to monitor for atypical lung nets?
Yeah, post-segmentectomy. Yeah, that's a good question. I think someone asked about chromogranin in another question. So, the short answer is for most people, no. There's not any kind of blood test. Now, exceptions are the occasional neuroendocrine tumors that make hormones. So the lung neuroendocrine tumors they don't commonly make the hormones that we measure, but they can. And the two that they can make serotonin, and that causes carcinoid syndrome, or they can make a hormone called ACTH. And ACTH causes the adrenal gland to make cortisol. So when you have a lot of ACTH, you have very high levels of cortisol. So if we know someone's tumor makes serotonin or ACTH, then we typically would include, occasionally in surveillance, we might check the hormone levels as another clue about whether someone might be having a recurrence. And those could be done, they're urine tests that are more reliable, but sometimes we can do blood tests as well. Okay. Now, chromogranin often comes up. Chromogranin is kind of a general neuroendocrine marker. There are some challenges with chromogranin, though. A lot of other things can influence chromogranin levels, including heart disease, kidney disease, liver disease, medications that people take. If you're on a proton pump inhibitor, that can affect chromogranin levels. So at least at UCSF, we found there was a lot of variability in chromogranin levels that did not track with people's disease. And it caused a lot of stress for patients when they had fluctuations in the levels if we couldn't explain why it was happening. So we have really moved away from routinely checking chromogranin. So for most people, it's really scans are the mainstay of surveillance. Now, there is an interest, I would say, across all of cancer medicine in trying to use tumor DNA, so blood tests that pick up very low levels of tumor DNA in the blood. That is an area like colon cancer, they're starting to do this. Certain other cancer types are starting to incorporate this into surveillance. And the technology's gotten really good for being able to detect low levels of tumor DNA. But the question is, what do we do with the information? And how do we act on it? And does acting on it early change people's outcomes? And we're not quite there yet. And certainly for neuroendocrine tumors, this is all experimental. There's not any study I'm aware of that has proven that using sort of these circulating tumor DNA blood tests and incorporating it into surveillance improves our ability to detect a recurrence and how people do long term. But it may be coming in the future because, again, this is an area of across all of oncology. There's a lot of interest.
Got it. Thank you. Folks, we got about 10 minutes left. We're going to try to keep pushing forward and get to as many questions as we can. Elizabeth says, are lung net metastases often more aggressive than a primary tumor?
They definitely can be. Yeah, they definitely can be. And sometimes the problem is more just the location. If you have it depends on location of the primary tumor. Sometimes if it's right in the middle, central part of the lung, it can cause problems and issues, bleeding, pneumonias, that sort of thing. But often the lymph nodes, it starts, in the lung and then spreads into the lymph nodes, and the lymph nodes end up causing more problems, or it spreads in a distant way into the liver, and liver metastases can sometimes end up being more aggressive than the primary tumor. So I would say that definitely can happen, Elizabeth.
Thank you. Lisa says, getting octriotide monthly is controlling my bronchospasms, but giving bad GI side effects, alternating Lomotil and Imodium. Any other solutions that you've seen that could help?
Oh, yes. This is unfortunately something we see fairly frequently. For folks that have carcinoid syndrome, starting octriotide can often help with diarrhea. But for folks that don't have a functional tumor, it's pretty common for people to have GI side effects. Octriotide is it's a GI hormone. And so it can cause diarrhea, it can cause bloating, that sort of thing. Sometimes it's a dose issue. All right. So I don't know what dose you're on, Lisa, but sometimes people are able to go down on the dose a little bit and they find that it still is enough to control symptoms, the bronchospasm symptoms, but it makes the GI side effects more manageable. Lomotil and Imodium are kind of our workhorses for diarrhea. And then there are other things we consider sometimes for GI side effects. I mean, there are other reasons people might have GI side effects, pancreatic insufficiency or gallbladder dysfunction. And there are different ways. It's sort of trial and error. We might do a trial of pancreatic enzyme replacements to see if that helps. We might try a medicine like cholestyramine, which can help with gallbladder dysfunction, see if that helps your GI symptoms. Sometimes people can have small bowel bacterial overgrowth, and that can be treated with antibiotics. So I do think it's important to also treat any other conditions or comorbid things that might be, that are more common in neuroendocrine tumors that could also contribute to GI side effects. And sometimes we do this in conjunction with a gastroenterologist. So if it really is limiting you, you could try going down on the dose a little bit. You could try working with a GI doctor, especially at an academic center, and kind of run through some of these other treatments to see if it helped.
Got it. Next question from Ioana. Let me know if I'm pronouncing that correctly. What specific type of mutation do you search for in genetic testing?
Yeah,
we were talking about that earlier.
We search for something that's called an actionable mutation, which means that there's a treatment linked with it. And the list of mutations that we can target is getting longer. So we usually don't do only 1 or 2 mutations. We use a panel, a broad panel, and there are some that are commercially available. There's a company called Tempus, Caris, Foundation Medicine. There's a host of these companies that have these commercial assays, and they test for anywhere between 100 to 500 different genes within the tumor. But what I'm looking for one that has a treatment linked to it. So for lung nets, again, a lot of it is overlapping with what we see in non-small cell lung cancer. So there's a list. You can have an NTRK fusion. You can have an ALK rearrangement. There's a list that I look for in particular.
Rochelle says, can gastric carcinoid tissue be stained for TTF1 to rule out lung nets for small nodules that showed up on a dotatate scan?
Yeah, you certainly could stain for TTF1. And then there are also GI stains that they do routinely that's another way to sort of rule in a GI neuroendocrine tumor if it's staining for some of the GI markers. So yes, you could potentially add that on.
And a follow-up question, is there any evidence of an autoimmune component with developing lung nets?
Not that I'm aware of, but there is some evidence that immunosuppression, which if you have an autoimmune condition, you may end up on immunosuppression to manage it, that can contribute to a more aggressive course if you have a lung neuroendocrine tumor. And this is really getting at the fact that our immune system is one of our defenses against cancer, just in general. And so if the immune system is suppressed, that may be needed and absolutely necessary to help prevent an autoimmune condition from causing problems. But it does seem to maybe not predispose people. I don't know that I've seen data about predisposing people to getting lung neuroendocrine tumors, but certainly if you happen to have a neuroendocrine tumor of the lung and you need chronic immunosuppression, we do at least worry that you may have a more aggressive course because the immune system is kind of put to sleep a little bit and can't help fight the tumors as well.
Gayla says, is there any information for lung nets taking Ozempic? This is a common question that we have. Does it cause any conflict? Is there anything to be concerned about?
I think more of the data is from pancreatic nets. I mean, there is some thought that some neuroendocrine tumors have GLP receptors on their surface. And there is some theoretical concern for how they might interact with neuroendocrine tumors and that they might and I think there's some preclinical, very limited preclinical data that they might activate some of these neuroendocrine tumors. Now, I'm not aware of for lung neuroendocrine tumors yet, lung net specific data. I think it's more pancreatic net. So I think it's an area to watch for sure. Hopefully we'll have some more information in the future because obviously these, those new weight loss medicines are really revolutionized treatment of obesity, but we want to make sure they're not going to negatively affect our patients.
Gotcha. One final question from one of your patients. From Cheryl, how can the NET community help reduce the gap in time to diagnosis? This is a common issue, waiting years and years sometimes. And obviously this is a big question. You're not going to have like a snap of the finger answer, but what are your thoughts on this? Is there anything that can be done? Where would you like to see attention and time and money and research being dedicated towards?
I think I lost you just for a second, but it's answering Cheryl's question,
Did
right?
you get?
Yeah.
Yeah. Did you get the gist of it?
Oh gosh. I think there needs to be
Right.
some. I mean, one thing I have been reflecting on recently is the fact that these are not actually that rare cancers, right? I think we, even as researchers and as a, doctor community, always talk about them as being rare. But if you look at the number of people living with this diagnosis, they're really not actually all that rare. And our treatments have gotten better, people are living longer, and we're diagnosing them more. They are becoming more common. And whether that's just a quirk of, we're picking them up more, or if the incidence is really rising, there's some debate about that. But we're diagnosing them a fair amount. So I think some of it is just in the way we talk about them as doctors, as patients, and moving away from calling them rare, because they're not actually that rare. And I do think if you think of something as rare, you might be less likely to actually have it on your differential. So that's one idea. And yeah, I think training is, there are certainly opportunities for training primary care providers too.
Gotcha. Folks, I just want to end today on a comment, not a question, from Kim. Kim says, "Hi, Dr. Mulvey. I am Jared's mother and wanted to thank you dearly for your medical help with his family. Unfortunately, Jared passed on May 10th, and we are so thankful for the 31 years here with us. Just wanted to say, Kim, thank you so much, and I wanted to take a moment to honor Jared, who is part of this community. Appreciate you being here very much, and all my love." Folks, that is our show for today. Dr. Mulvey, thank you so much for being here. As a first-timer, I got to say, you knocked it out of the park. Great answers, great, easily understandable answers, which is very important for a complex and not rare disease, but a complex cancer. So I appreciate your time very, very much.
It's my pleasure being here. And yeah, thank you so much to Jared's family. I mean, I think he was 31, it's just... reminder to all of us that we need to do better in having better treatments for our patients. So thank you so much for having me on. I really appreciate being here.
Absolutely. And folks at home, we appreciate you joining us. We like to have, a little bit of levity here on the show and lightheartedness, but we don't take this for granted. This is heavy at times and tough and hard at times. And that goes back to my initial point about the strength of this community, which is why it's so important that we continue to help strengthen this community for exactly those reasons. So I appreciate you all being here as always. I hope this program helped answer some of your questions. And you can always follow up at ncf.net/support line if you have any questions in the meantime, and we will be back in 2 weeks. Finally, my name is Rain Bennett. Thank you for watching, and please join us next time on Luncheon.